I'd like to welcome everybody to tonight's program, an update on the role of ctDNA in the management of early-stage colon cancer. Tonight's discussant is Dr. John Stricker, who's been instrumental in working with this technology from its inception. John is from Duke University, and with that, John, we'll turn the program over to you.
Yep. I'm John Stricker, a GI medical oncologist at Duke University, here to discuss updates from ASCO GI with respect to the Circulate Japan trial. So as background, one of the most interesting and innovative developments in the realm of adjuvant treatment for colon cancer is this use of a new technology called molecular residual disease testing. This involves removing the tumor from the patient, performing whole exome sequencing on that tumor, and then designing a custom panel that can be used to generate blood-based testing to look for residual disease. There have been a number of studies over the last several years looking at the prognostic performance of this assay in various patient populations with colon cancer after resection. The Circulate Japan study, which I plan to present here, is one of the most extensive studies looking at the performance of this assay in a real-world setting. Now, the Circulate Japan study is a huge project involving 1,500 patients who are enrolled between June 5th, 2020 and April 30th, 2021. So it's relatively new evidence that's been generated. From this, 1,040 patients were included in this analysis. About 500 patients were excluded, either because they didn't meet criteria for analysis or because they were enrolled in some interventional trials that I'll mention briefly. So in this 1,000 patient cohort, there was a dynamics analysis cohort where they're looking at what happens to patients who have serial blood draws, one immediately after surgery and then one 12 weeks later. They also have a clearance analysis cohort that looks at the performance of the assay when that circulating tumor DNA changes. And then finally, they have a ctDNA negative cohort where they're looking at the prognostic significance of getting chemotherapy when your ctDNA is negative. So overall, the patient characteristics were fairly well balanced between males and females. It is a broad representation of the colon cancer patient population, including all stages 1 through 4. The first important note is that they confirmed what has already been known, which is that at that single blood draw 4 weeks after surgery, a negative result is very strongly predictive of excellent prognosis. So in their analysis, after about a year of follow-up, they found that a single post-op negative led to a 93% 12-month disease-free survival. Contrast that to a positive result at that first post-operative visit, and the 12-month disease-free survival is only 47%. So there's an 11-fold increased risk of recurrence for patients who are positive at that first post-operative time point. Additionally, looking specifically at the stage 2-3 group of patients, a very similar result, 13-fold increased risk of recurrence if there was a positive circulating tumor DNA test at the first post-operative visit. And when you compare the performance of that molecular residual disease assay against other demographic or other risk factors, ctDNA vastly outperformed the other more traditional risk factors as a predictor of recurrence. Now I want to explain for a few moments about this so-called dynamics analysis cohort. As a reminder, this is 838 patients where they were able to check blood at the single post-operative visit and then 12 weeks later. What they found is that patients who had positives at both the 4-week and 12-week visits had a very high risk of recurrence. So the 6-month disease-free survival was 58%, as compared to 98% 6-month disease-free survival for patients who are negative at both visits. But what's interesting in this Circulate Japan data is what happens when the circulating tumor DNA result changes. So in the group of patients who were negative at their first post-op visit and then were positive 12 weeks later, the risk of recurrence was quite high. So a 6-month disease-free survival at 62%. Interestingly, they also looked at patients who were positive at that first post-operative visit and then switched to negative. Interestingly, none of those patients recurred at the 6-month follow-up visit. Next, looking at that clearance analysis cohort, this is patients who received adjuvant chemotherapy or did not, and looking at whether that change, whether there was clearance of circulating tumor DNA with adjuvant chemotherapy. Interestingly, the odds of clearance were about 9-fold in patients who received adjuvant chemotherapy compared to those who did not receive adjuvant chemotherapy. This data is observational, so we do need some follow-up and some interventional trials, but it does suggest that giving a patient adjuvant chemotherapy who's ctDNA positive at that post-operative visit may actually change the trajectory of that disease and may decrease the risk of recurrence. And that has been that's been shown as well by looking at disease-free survival in patients who receive adjuvant chemotherapy that are ctDNA positive. And then finally, and this is data that we've all been waiting for, looking at what to do about patients who are negative at that first post-operative visit and whether adjuvant chemotherapy is helping them at all. Interestingly, there was no difference in 6-month disease-free survival and 12-month disease-free survival for patients who got adjuvant chemotherapy compared to those who didn't, suggesting that in patients who are negative at their first post-operative visit, there may not be a role for additional chemotherapy. We might be able to spare these people adjuvant chemotherapy. Now, this is very early observational preliminary data, and it does need prospective validation. But this data is very important to us. It suggests that we should be performing these prospective randomized trials to see whether adjuvant chemotherapy helps these patients at all. So we are looking forward to seeing the prospective validation of these observational findings. We will be looking out for both the VEGA trial, which is looking at randomizing patients to no chemotherapy versus chemotherapy, where ctDNA is negative after surgery. And then the ALTAIR trial, which is looking at intensifying chemotherapy in patients who remain positive with their circulating tumor DNA. All very interesting results, and we expect to see this updated in conferences to come.